Rectal cancer occurs in the lower end of the digestive tract and can affect normal bowel patterns and cause a variety of symptoms. My patient was a 75-year-old male admitted on November 1st. He is a full code and is allergic to amoxicillin and povidone. He has a past medical history of acute renal failure, anemia, hypercholesterolemia, hypertension, insomnia, and rhabdomyosis. He came in for complaints of abdominal cramping, fatigue, and intermittent constipation. The doctor performed a rectal exam and obtained a stool sample along with a CBC and CEA. His admitting diagnosis was stage 2B rectal cancer, due to positive blood in the stool and a colonoscopy ordered found cancerous polyps. This means the cancer has extended into the mucosal layer of the rectal colon. The patient had symptoms of weakness, and as symptoms progressed, he felt that his abdomen was tender and he noticed a change in his bowels. Most people with this early or late rectal cancer experience fatigue, weight loss, changes in stool, abdominal tenderness, palpable abdominal mass, hepatomegaly, bloating, intermittent constipation, and feeling of incomplete stool evacuation. During his hospital stay, he did not receive chemotherapy or radiation, but received an abdominal perineal resection, or APR. This incision is made in the abdomen and around the anus to remove it. He now has a permanent colostomy on his left side. None of his medications are related to his rectal cancer, but he is receiving acetaminophen for pain. He also had a urinary catheter to measure his output, and the patient also told me he will be starting chemotherapy in about 4 weeks after surgery. Follow-up care would include a physical assessment to be done every 3 to 6 months for 5 years, and a CEA test, which is a blood test that detects the presence of cancer and shows whether it has spread to other parts of the body. A CT scan will also be recommended, and this creates a 3D image of the inside of the body to detect cancer spread. This should be done every year for 5 years. He will also receive another colonoscopy 1 year after surgery to detect reoccurrence of cancerous polyps. A rectal sigmoidoscopy would also be recommended every 6 months. It is where a tube is inserted to check for polyps and cancer. Goals and interventions while the patient is in the hospital will include dressing changes as ordered or needed. He also had a JP drain that was removing excess fluid from his abdomen. This will need to be watched and drained during his stay. He will need to be reminded to cough and deep breathe while splinting his abdomen to prevent further injury. The patient may not want to cough, or he may try to hold it in, so I'll offer a pillow to splint his coughs. The patient is on enoxaparin to help prevent blood clots. I should remind him to move his legs while he's in bed to help promote the flow of blood. He also has a urinary catheter that requires catheter care and needs to be drained and watched for INO. A clear liquid, low-fiber diet will also be recommended in the beginning to slow bowel movements and relax the digestive system. The patient may be apprehensive about diet changes, but remind him that this will help him heal faster. Stoma care will also be important. This includes emptying and proper assessment. Self-image may be a concern for the patient, so I'll be available to answer any questions. Walking should also be encouraged. I'll tell the patient that this will help him feel better so he can keep progressing. The proper referrals needed for a patient with rectal cancer include a dietitian, a radiation oncologist, a gastroenterologist, a medical oncologist, and a surgeon. According to the article, a dietitian is important to help relax the bowel with dietary modification and monitor nutrition before and after treatment. A radiation oncologist may be needed to prevent reoccurrence of the tumor, and a gastroenterologist will discuss problems and treat the digestive tract. A medical oncologist will help with chemotherapy, and a surgeon will remove the tumors and treat the disease. I will want to educate the patient that he may experience phantom rectal sensation, which is when the patient feels the need to evacuate the stool out of the rectum. According to the article, I will want to discuss sexual dysfunction and diet modifications, such as decreased spices, fat, and insoluble fiber. The article also says we need to be more proactive with bowel interventions when it comes to treatment. It says that early interventions can reduce levels of chronicity and increase cancer survival rate. I will also want to discuss colostomy care and signs and symptoms of infection, such as redness, fever, and swelling. I will also want to address dressing changes and when to change them and how to change them.